It's really a pleasure to be here. Spare my hand for holding this microphone. And as a way of introducing myself, I'm a neurologist, as you heard, and I see patients, but I'm also engaged in clinical research. I'm full-time faculty here in Westwood at the medical school at UCLA, where I direct the Epilepsy Clinical Program in the Department of Neurology. I see patients of all types, of all ages, down to adolescents, and engaged in the care of many patients with epilepsy. It's a large neurology department at UCLA, and so the neurologists tend to be subspecialized and allows for developing an expertise in one area of neurology. So I was asked to speak to you today about seizures and epilepsy, and I know from my experience speaking to many people over the years, is the entire topic is really quite confusing, can be baffling, and can be scary. And so what I'm hoping to do is to share some understanding, bring some clarity to this topic, and educate you toward the breadth of manifestations and treatments that are available. It's a small enough group that I feel like we can have some dialogue and some questions. And so if there's something that really needs to be clarified, please feel welcome to raise your hand. I don't mind stopping and going off on a little bit of a tangent to clarify that and make it more useful for you as a group. And I'll probably repeat the question after you ask it, just so that the recording will have that question included. So where I want to start is with something that most people don't realize, is that there is no disease, as in a single disease, called epilepsy. Epilepsy is a condition in which a person who has it has an intrinsic predisposition, meaning by nature they're at greater risk, to have seizures. And it's that intrinsic predisposition, that inherent risk that they have for the seizures, which allows them to be diagnosed with epilepsy. In other words, seizures can occur in somebody who doesn't have epilepsy. And I think this is a point really to start by talking about seizures and get back to epilepsy as a whole. A seizure is a state. It's a temporary condition within the brain in which the brain's function is disturbed, but it's disturbed or altered because of a particular sequence of events and particular pattern in which the activity of the brain is altered by an abnormal connection or abnormal rhythm between the cells. And during that state, the person's thinking, the person's awareness, the person's movements are altered. But then the seizure ends, and the person goes back to normal. And so seizures are episodes. And in some ways, going back to the idea of epilepsy, there's no more single disease called epilepsy as there is a single disease called headache. When someone says, I have headaches, it doesn't say much about what type of headache, how often they occur, how debilitating they are, but you do know that they are having occasional headaches. And so with epilepsy, all it means is that the person has had seizures and they are at risk for additional seizures, but it doesn't say anything about the severity of the seizures, the frequency of the seizures, or anything else about them. So that's an important part of this, that epilepsy is it's a tremendously diverse condition, and that people can have very infrequent seizures, a few seizures all in their lifetime, or people may have disabling seizures, or seizures that don't respond to treatment. So I'm going to go back to seizures again and talk about what it means to have a seizure. The seizure is that disruption of function within the brain, and how it disturbs the person's experience depends upon where that disruption occurs, because the brain is not all the same all over the place in the brain, as well as how far that abnormal rhythm travels within the brain. And so a person can have a seizure, which is probably what you envision when I say seizure, of what's been called a grand mal seizure historically, in which a person has stiffening and collapses, and there's jerking and injury. And it's very scary, and it looks life-threatening. And that's one type of seizure. That's been called a generalized seizure in more current terminology. And that seizure can start with one small area of abnormality, where the rhythm begins in one location and spreads out within the brain to produce a convulsion. Or it sometimes can start where the rhythm is more widely distributed in its abnormality. And so one way to think about this is the idea of, if you think about a body of water, and somebody is dropping a pebble or a drop of water into the body of water. And the water hits the surface, and there's a little bit of ripple. And so the problem is where the water hits the surface, and the larger pond, or let's just call it a pond, is disturbed based upon how big it is and how far it travels. But the pond itself is fine. And so you think about a seizure as that ripple going through the brain. And so the problem is not where the ripple travels, the problem is where it started, what's disturbing the surface. That's kind of like how a seizure is, that a seizure can start with one region and then spread out. And so the experience a person has at the beginning of a seizure depends upon where that little ripple is. And sometimes people have warnings at the beginning of a seizure. A person might experience a sensation or have a certain emotion as being the part of the beginning of the seizure. This has been called an aura. It's the medical term. I'm going to throw medical terms into this, so in case any of you have already heard some of these terms, you can put it into the context of a better definition, or if you want to compare the definition to the medical jargon, you can. But the aura, the warning of a seizure, is actually the very beginning of the seizure, based upon where it occurs. And if a person has that sense of whatever they have, a strange aroma they experience, or a movement, that may indicate where the seizure begins. And as the seizure spreads, like that ripple across the surface, it may then become something much larger and envelop otherwise fine regions of the brain. But then as it settles down, it's back to normal. And so that's the episode, that is a seizure. And so seizures are thought about according to how they start and what manifestations that occur during it. And that gives us information about the risks of an injury or what to expect during the seizure, but it doesn't really tell us anything about the underlying condition. It's more about location than cause. It's not telling us whether it was a pebble dropped into that pond of water or a droplet of water or something else. It's just the manifestation. Seizures are relatively common in the population. When a person is born, they have about an 8 to 10% chance of having a seizure at some point in their lifetime. So maybe 1 in 11 people approximately will have at least one seizure, which is, I think, more frequent than most people think. That's more frequent than I thought when I first learned that statistic during my own education. And so I think part of the reason it's more common than we think is that it's not something people talk about much. Because people tend to not want to think about it. It can be scary and it can be distressing, and so it's not part of our usual conversations. And that's despite the fact that seizures have been described for millennia. The history of epilepsy and seizures goes back to the history of written medicine, thousands of years, because when a person has a seizure, especially a seizure that's as concerning and scary as the convulsion I described of falling, it's quite noticeable, and people have been recognizing this as an abnormality since the beginning, well, before written language. And so I think that despite that longevity, it's still something that people tend not to want to discuss. And so maybe that's why the frequency is beyond what most people expect. But having a seizure does not mean having epilepsy. Going back to what I said earlier, that epilepsy is a condition where a person has intrinsic risk to have more than one seizure. And so in fact, the lifetime risk of having epilepsy is closer to maybe 2.5 to 3%. And so overall, if you think about it, only about a third of people who have a seizure actually have epilepsy. And so what does that mean? I mean, that means that if you hear a person's had a seizure, odds are, 2 out of 3 chance they actually don't have epilepsy, if you don't know anything more about them. And so the question is, well, why did they have a seizure? And there are many reasons for that, but understanding what the cause was for the seizure is helpful toward thinking about what care they should receive. So causes for seizures can be a medication reaction. Certain medications, as a side effect, can cause a seizure. Fortunately, not many medications, but this is well established. If somebody's blood sugar goes way too high or way too low, especially in the situation of diabetes, this can cause a seizure. If somebody takes an intoxicating substance of abuse, cocaine, for example, can cause a seizure. Somebody who regularly abuses alcohol, drinks regularly, very often, for a long time, and then stops. During the sobering up, a seizure can occur as a reaction to the detox from alcohol. All these can cause a seizure, but each of these situations that are not related to epilepsy, obviously the best thing you can do to prevent another seizure is not put yourself in a situation that caused that seizure. And so that's not a condition to be treated as an epilepsy. That's a condition to be treated in the sense of optimizing health to prevent the circumstance that caused that seizure. It's that 2.5 to 3% of the population whose seizures are not caused by circumstance who have epilepsy. And epilepsy, going back to what I said at the beginning, It is a condition where a person, because of their nature, because of the way they're made, has a risk of having a seizure even outside of circumstances that may cause a seizure, meaning that person's not doing anything that would provoke a seizure of the types I described, either medications or health circumstances, or prolonged severe sleep deprivation could even do it, but it just happens. And so the question there is what can be done to prevent it, and it comes down to being on a treatment for epilepsy. So when we think about epilepsy, I said earlier that it's not a disease, it's really a collection of conditions that have one thing in common. And that one thing is that intrinsic predisposition, that inherent risk for additional seizures. And we approach the epilepsy according to several factors that help narrow it down to different types of epilepsy. And that's important because what we do in medicine in general is we try to figure out what's the most exact diagnosis possible, because that is hopefully, the aspiration is always that the more exact the diagnosis, the more exact the treatment can be, meaning the more effective and successful the treatment can be. And so when we think about epilepsy, we think about what caused it and what type of seizure occurred during it. And the epilepsies have different forms, according to partly to what type of seizure occurred. Was that seizure a focal seizure, which starts kind of like that drop into the pond, spilling out? And if so, where did it start? Or is it an epilepsy where you can't really find one location, it starts more diffusely? Maybe if you want to stick with the water analogy, you could say, think of it more like a tank of water, where suddenly it gets jostled, and the waves are occurring more widespread across the surface than one spot. And identifying which type of seizure of these two types is important because that will steer the doctor toward finding the medication that's more likely to be effective. The epilepsies also can be broken down to certain, they're called syndromes. And a syndrome is medical jargon for a constellation of several features that tend to come together. And these syndromes are based upon the age of onset for the first seizure, diagnostic testing, other problems the person might have, maybe it's more than one type of seizure. And getting to that specific type of epilepsy, that epilepsy syndrome, which is not always possible, can be helpful again for finding the most effective treatment. I said earlier that with epilepsy there's this intrinsic risk, and the question is, well, what's the intrinsic factor? What is the cause if it's not something the person's doing? And we know now that there are many possible causes, because anything that disrupts the brain's rhythms to cause that abnormal wave can cause a seizure. So anything that disrupts the brain's function to cause that risk can cause an epilepsy. There are genetic causes for epilepsy. There are more now than were known in the past because we're living in an era of increasing sophistication in genetic analysis. But most of the time, we don't have a genetic cause for an epilepsy. And many times, it might be more than one gene. And you think about it, it's like any health condition. What causes heart disease? Well, there's going to be a genetic predisposition. Maybe it's more than one gene. There's going to be a lifestyle factor as well. Maybe part of this is true for any medical condition, but maybe true for epilepsy as well. There might not be one gene, but it might be a combination of genes, but it also might be other factors. And where I said lifestyle referring to the heart, which all of you are thinking about diet and exercise. For epilepsy, it's really what keeps the brain healthy. And part of that could be injury. So if the person's had a serious head injury, that can be part of the factor that causes it. And that injury can be a concussion or a very serious blow, where maybe there's damage to the brain because of the severity enough to cause a fracture to the skull. Or it could be injury inside, if there's a circulatory problem, blood flow is affected, or there's a little bleeding at some point. But it doesn't matter the type of injury, it's really the location and the circumstance. It's also possible the brain, in a way, just formed irregularly, and maybe has no consequence at all, except for the wiring being irregular at one location and then manifesting seizures because of that. And I saw a hand up for questions, so please.
Is it the same as a mini stroke?
So the question is a seizure the same as a mini stroke? And the answer is that it's quite different. In that a mini stroke, or sometimes called a TIA, or transient ischemic attack, is a brief episode which would be like a seizure in that it can last only minutes. But the difference is that the transient ischemic attack is due to a brief interruption of blood flow to an area, and that interruption of blood flow ends up compromising or blocking the function of that area until the circulation is resumed. With a seizure, if let's say a seizure occurred in the same area, the problem could be similar, or not, but the problem is not due to a blood flow interruption. The problem is due to an irregular electrical rhythm through the area. And so the circulation is fine. And a seizure wouldn't necessarily put a person at risk for a stroke, a true stroke, which is what the major concern is after a mini stroke, is that area is vulnerable, and that's when there can be action to try to prevent a stroke down the road. With the seizure, it's really a matter of preventing that electrical rhythm. The other difference is that with a transient ischemic attack, there's a loss of function. A person might find weakness or numbness. You know, they lose their movement, they lose their sensation, or lose their speech for those minutes that it occurs. With a seizure, most likely, or most often, it's not a loss of some function, it's the creation of some problem. And so instead of being weakness, it might be jerking. So it's a movement instead of a loss of movement. Or it could be the experience of seeing something that's not there instead of losing vision. Does that answer?
Which is more serious.
Your question, which is more serious?
Serious.
Yeah, I can't answer the question which is more serious. It really depends on the circumstance, and I think you realize that from your, yes. Good question. I said that there's a diversity in the epilepsies, and some people might have just a few seizures in their entire life, and that's it. And some people may have much more concerning, even disabling condition. And that diversity is something that in some ways can be predicted, sometimes not, when the situation develops. But the important thing when diagnosis is made is to try to stop any additional seizures, but recognize that when a person is treated, it may not be lifelong. That sometimes the problem does go away on its own. And identifying whether this is an epilepsy that naturally just goes away. That can happen with childhood onset, which I think most people hear about the child who had seizure but grew out of it, is the term. But it also can occur with an adult. And this, identifying who has grown out of it, whether they're growing out of it as a child or growing out of it as an adult, is really a vexing problem, especially for the adults. But my point really is that there's a variety of natural courses that don't always go toward the more serious, nor do they necessarily go to the benign. And so ultimately what we have in front of us is trying to minimize the seizures in the present time and then deal with the question that we want to have as a problem as to whether additional treatment is necessary. Until the seizures are controlled, there are consequences that become obvious when you think about it to having seizures. And I think the real problem ultimately for epilepsy is the fact that the seizures do two things. They cause a loss of awareness or a loss of consciousness, and they occur randomly or unpredictably. And so if you think about it, if a seizure was only a jerking of the left arm that lasted 3 minutes and then stopped, that would be a problem. That would not be disabling or necessarily injurious. Or if the seizure, if it did cause loss of consciousness, but only did this at 2:30 p.m. on every other Wednesday, the person would be able to prepare themselves for that occurrence and minimize the risk of any harm. But the fact that it's the combination of loss of consciousness, impaired awareness, some overall neurologic compromise, at times that are really random, is what creates a very serious concern for safety. And so the person whose seizures are uncontrolled is at risk for injuries, even fatal injuries, because of the seizures. And so the first thing people think about is driving, and that a person whose seizures are not controlled is not safe to drive. Each state has its own laws for licensing, but putting that aside, just a matter of safety. Because if a seizure occurs, even with a very short warning, in a very fast-moving car, that person's at risk to injure themselves, but also at risk to injure other people. And that's, of course, something no one really wants to occur. But beyond driving, it becomes a question of any activity that would put the person at risk or put someone else at risk of a serious injury if there's a sudden loss of consciousness. And so this limits a person's recreational activities. It doesn't eliminate them, but it does mean that certain things should be avoided, you can't be engaged in. And so I'm thinking about, the obvious ones, when scuba diving, skydiving, really adventure sports. But then the question becomes mountain biking on a trail, somebody who's active in that way. Or if you fall, is that going to cause a serious injury? But it becomes maybe a matter of thought in that swimming alone. Swimming is not a dangerous activity if you know how to swim. But if you're swimming alone, you have a seizure, that can cause drowning. So there's a limitation there, but that can be overcome by having somebody present who can intervene if there's that unlikely possible occurrence. Or with exercise in terms of weights, it's a matter of knowing that if a seizure occurred, what would happen? Would the dropping of the weight cause a serious injury or would it just fall to the ground? So it's a matter of modifying lifestyle accordingly. And so until seizures are controlled, there are going to be necessary safety restrictions and limitations, but even with these restrictions, there can be injuries. And so there is a well-studied, well-known fact that people whose seizures are not controlled are at risk for serious injuries like cuts and burns and things that can occur to anyone through our daily lives of cooking and hobbies. And seizures, even if they don't produce that injury, still can produce a risk for sudden death, which is a tragic circumstance that is the greatest risk for somebody whose seizures are not well controlled, especially if they occur during sleep and especially if they are for convulsions, where it becomes an issue of suffocation, which is a horrible situation that is being studied very actively presently to try to figure a way of reducing that risk, even independent to the risk of the seizures. And so, I hope to have communicated so far is that there are a variety of ways seizures can manifest, and seizures by themselves aren't epilepsy, but are a marker of epilepsy in somebody whose seizures are not provoked by circumstance. And the epilepsies are also really quite diverse. But regardless, it's really critical to come to an exact diagnosis and get seizure control. And so I'm going to transition at this point to talk about the diagnostic approach. What happens when a person who's had what they think are seizures, someone says you had a seizure, or something like that, and they go to a doctor. What is the doctor thinking, and what's the diagnostic approach that leads to what I was just discussing? And the reality is a lot of the diagnostic approach is just getting a very, very detailed history, meaning a very detailed story of what happened. And it's important for that story to come from the person who had the seizure, as well as any witnesses for the seizures. Excuse me, just take a sip of water. There's a maxim that medical students learn that says that 80% of getting to the diagnosis is getting a very detailed story. And in neurology, we talk about it being 90%. Because getting a very detailed story about the experience and what happened is an important part of making an accurate diagnosis. But for seizures and epilepsy, sometimes it's 100%. Meaning the story, the description, by itself, can be all that's necessary. Sometimes it's all we have in terms of making an accurate diagnosis. And so that story needs to have details about the person's experience, the circumstances, what risk factors may have been present beforehand, and also what witnesses observed. And the twist is, one reason why witnesses are so important is that when a person loses awareness, they're unable to provide a story for what happened. It's obvious. And so the observer can provide as much of the important information as the person who has had the seizure. Because that person who had it may not be capable of remembering or knowing what really happened. That's why it's so important to get that detailed story. The two diagnostic tests that are routinely obtained, and really important, are the EEG, which is the electroencephalogram, and the MRI, which is of course the brain scan. The EEG is maybe the equivalent of the EKG for the heart. The electrodes placed on the chest. But here the electrodes, the little contacts, are pasted on the scalp. It's a recording of the ongoing brain electrical fields or electrical activity. And these recordings give an indicator of if there's any electrical disturbance present. And this disturbance, this abnormality, can be present between seizures. And it usually is present when in a person who has epilepsy. And it often is present even if they're not having a seizure. So one common misconception is that you have to have a seizure for the test to show something. And that's not true. The test can show whether a certain area or a larger area or whatever is electrically abnormal. And because of that, based upon the shape and the location and the features of this wave that the expert visualizes, can give a sense as to whether this person is at greater risk or lesser risk for initial seizure, and can give an idea about what type of epilepsy it is. But the EEG can be normal in somebody who has epilepsy. And so it doesn't exclude the diagnosis, it helps clarify the diagnosis, and it helps pinpoint what type of epilepsy. And so, I'll just repeat it again, that a normal EEG does not exclude the diagnosis. It doesn't mean that this wasn't a seizure. It just means the test failed to show something. And you can't be upset for something to be normal, even if it's not informative. The other test is the MRI, and that's the test where the person goes in, of course, inside the tube and a picture is taken. And the MRI is different from a CAT scan, that the MRI provides a much more detailed picture of the brain than a CAT scan can. A CAT scan uses X-rays. The MRI uses magnetic fields. But it's important to have the MRI because the MRI's detail is much greater than the CAT scan's detail. And I said earlier that a very small disturbance to the surface of that pond can cause a big ripple. And so even a small area of abnormality in the brain, one that's not consequential in any way, other than its electrical irritation, can cause a seizure. So it doesn't have to be large, it doesn't have to be concerning in any other form, but it can still be important. And so it's important to have the scan show that very high level of detail. If the testing is inconclusive, if the episodes are not convincing in their description to be seizures, the next step in the diagnostic evaluation is for the seizures to be recorded. And this is conventionally done inside the hospital. The person being admitted, a scheduled admission, to have a long recording of the video and EEG. This is possible when the episodes are occurring regularly, where you really want to be able to see one of the episodes. So if a person's had a couple episodes years ago and you're not sure if they're seizures, it may not be fruitful to have an admission to the hospital for testing. But if they're occurring once a week, more often than that, and I don't really want to put a time window down what's necessary, that's where observation for recording can be helpful, because seeing it is critical, and that can be an important part of the diagnosis, because maybe they're not seizures, maybe this was a misdiagnosis, maybe the story is not as clear as it needs to be in order for the doctor to feel confident where the diagnosis is. And as I said earlier, the more exact the diagnosis, the more exact the treatment. And so knowing what the diagnosis actually is really critical. There are other tests that are being used in diagnosing epilepsy that go beyond what I just described, but these are tests that are used in special circumstances, especially when treatment has not been successful. These are tests that are more often available only in university settings, and it's probably not worth going into those right now. So I'm going to take the next step and talk a little about treatment, taking the assumption that this hypothetical situation has led to the characterization of the person as having seizures. This is epilepsy, the seizures are not provoked. And beginning treatment for prevention of seizures is necessary for preventing injury, preventing disability, preventing all the negative consequences that go along with having a seizure or multiple seizures. And treatment conventionally begins with medication. We have about 24 anti-seizure medications in the United States presently. And the number of medications has increased progressively over the past 20 years. So it's been a very successful time for medication development in neurology in particular. The medications work through about a half dozen different mechanisms. And so it's not all the same thing over and over again. But there are some families of medications that you can say these medications sort of belong together in a family based upon how they work. But regardless of how they work specifically, medications all have one thing in common. They are discovered or designed or they come into our use because of their capacity to prevent the abnormal rhythm that is the seizure. Sometimes they're called anti-epilepsy drugs, but that's a bit of an overstatement because they don't do anything to undermine or prevent the epilepsy, that risk. They're more like anti-seizure medications because they stop the seizure when it occurs. And so it's kind of equivalent of a pain medication doesn't get rid of the cause of the pain medication numbs the area for the pain. And so you want to, if you can, eliminate the epilepsy, but we don't have a medication for that really. We have medications that help prevent seizures. The medications do differ according to what type of seizure they are most effective for. Most of our medications are effective for focal seizures, the ones that start in one location. We have fewer that are effective for ones that occur more widespread across the brain all at once. We have several for those. And in fact, there are different types of seizures that are more widespread or what are called generalized. And so sometimes it becomes more targeted in medication selection according to what type of seizure the person's having. This is where having a doctor with some expertise for the seizure types and the medications can be helpful, because one reason a person's seizures may not be under control is maybe they're on the wrong anti-seizure medication for them. It's really quite individual. An important point is that we don't have the best anti-seizure medication. That doesn't exist. There's no, this is the best, this is the second best. We don't even have, these are the best 5. What we do know is that the medications overall have more or less similar benefit across large populations of people. But for individuals, one might work really well, and another one might not work at all. And we don't have a way of knowing that in particular. What we do have knowledge of is that the medications do differ in their safety and side effects. And so obviously, when choosing a medication, it's best to choose something that's likely to work for that seizure, but also something that's not likely to cause a problem or any side effects. And the side effects do differ according to the medications, across the medications. Just to give you a few examples, some medications cause more drowsiness, some cause more mood change, some cause more sense of coordination change. But those are the overall side effects that are more common among medications, but differing with the different ones and according to different people's vulnerabilities. When starting treatment, it's typical to start for a few years. Usually we think about if a person's diagnosed, it's worth being on medication for 2 or 3 years. And if the person's seizure-free for that period of time, that's a time where it might be worth thinking about whether the medication is still necessary. But the goal is to get the seizures controlled. The problem is that medications don't always work. And there is something called medication-resistant epilepsy, which is just that. It's when medications don't work. And a person's tried several medications, 2 or 3 medications without seizure freedom. And that becomes a much more serious situation because their seizures are continuing to occur. And even if they're better, even if they're less frequent or less severe, the risks are still there for injury or other consequences of the epilepsy. And that's where reconsidering the diagnosis and thinking about other treatments is really most important. Sometimes medications have failed because there's been a misdiagnosis of the type of epilepsy. And I talked about the specificity before. This is the situation where coming into the hospital for the video EEG recording to record the seizures is helpful because it might end up pointing the doctor toward a more specific treatment. Or sometimes maybe it's misdiagnosis, maybe it's not epilepsy. And so being on an anti-epilepsy drug or an anti-seizure drug specifically is not going to help. Maybe there's something else, another treatment that would be more beneficial for that patient. If the evaluation does show that this is in fact epilepsy and that in fact it's not responding to the medications we have and appropriate medications have been used, then there are other possible treatments. And so we fortunately have Plan B and Plan C in treatment. It's never a point of saying, well, okay, there's nothing that can be done. There's good evidence for certain diet therapies being helpful. That's, I won't get into the details of that, but some diets, people have been talking about ketogenic diet, which is really a pediatric or child diet, but people are talking about low carbohydrate diet and benefit there. Something really talk more to a doctor about before trying it. But there's also surgery. And so if the epilepsy is due to one small abnormality, maybe it's something the person was born with and has no consequence other than it's just this one anatomic abnormality, but it happens to be electrically irritated enough to cause the seizures. And removal of that abnormality, a surgery, can be very effective. And for certain types of epilepsy, there's a more than 80% chance of seizure freedom after surgery if the seizures were found before surgery to be referable to that area and that area was safe for surgery. And we know that the chance of living successfully, living at all is increased by surgery in those situations because of the consequences of uncontrolled seizures. The surgeries have different approaches. Some are laser, some are more traditional. It really depends on the patient and what the needs are. But there are other possibilities as well. If more definitive treatment can't be provided with surgery, there are now 3 devices that are stimulating devices that are helpful. And by now I mean that this year the 3rd device was approved by the FDA. The first device is called a vagus nerve stimulator. It's an implanted device, and the device sits here in the shoulder and attaches to a nerve in the neck called the vagus nerve. And what we know is that stimulation of this nerve with a little bit of electricity has an effect on the brain that decreases seizure likelihood. And so it can be effective as a way of decreasing seizures when medications haven't worked, when other treatments aren't possible. The second device is called the responsive nerve stimulator. Sometimes called a NeuroPace device. And this is a device that's placed on or within the brain, so it's a much more invasive surgery. But it's possible when the location for the seizures has been identified, but surgical treatment to remove is just not a reasonable option, not a good option for that patient. And this device sits on the brain, and it's kind of like a cardiac defibrillator in an analogy. It's not the same to the engineers. What it does is it's recording brain activity at that location and detecting the abnormality to indicate a possible seizure, and then electrically stimulating at those times to stop the seizure. We've known for many, many years that if you electrically stimulate directly to the brain, you can stop a seizure. But we didn't have a possibility of a device that would be so small, so smart, to be able to provide that. And so that device is also conventional treatment now, FDA approved. The third device, one is newer to the United States, but it's been available in Europe for about a decade, is a deep brain stimulator. And some of you have heard of deep brain stimulation, or DBS, for Parkinson's disease or tremor. And it's really a very similar device, but it's placed in a different location in the brain. And it's placed in a location that can help prevent seizure spread. And so it's like the other two in that it helps stop seizures from spreading out and make the seizures less frequent and less injurious. So the technology available to us is really quite broad. We have new medications. In the past few years, it's been a new wave of new medications. Several things are in the pipeline that look promising, but we'll have to wait and see. But ultimately, the point is having treatments available for patients whose seizures are not responding and using the medications smartly, because seizures are bad, and seizures control and seizure freedom needs to be achieved, and needs to be achieved with treatments that are not going to cause their own problems, other medications or otherwise. And so that's the end of my prepared statements. I'm happy to answer any questions you have. And I see there's one already back there.
Well, this doesn't apply to me or my family, but I wonder where parents, well, is that your medical card on the table?
No, it's
No.
not.
Oh, well, where can parents, and other people, grown-ups, obtain the marijuana oils that are said that some parents I've seen on TV say help their child, and probably adults too?
Yeah.
How can you safely obtain those?
So as of this week, you can safely obtain them through a prescription from your doctor, because one version of that has been FDA approved and is now available as a regular medication. And so I can speak for a few minutes about that if there's interest, and that's something called CBD, or cannabidiol. And so marijuana has about 100 different cannabinoids in it. And these different cannabinoids are different molecules that have different biological effects. The cannabinoid that produces the high of marijuana is something called THC. And that has not been shown to be effective for seizure control in any clinical studies. CBD is another compound in marijuana, and this has been shown in very rigorous, well-structured clinical studies to be helpful for certain types of seizures. And based upon that evidence, the FDA approved CBD for these forms of epilepsy. And as of this week, actually, it is available for prescription in its pharmaceutical grade, pharmaceutical purity, pharmaceutical consistency of the CBD, of cannabidiol. So it's not an issue at this point. There are dispensaries that have produced CBD as well, and so the question that I always receive about those is how do you know what's really in it? How do you know how much is in it? And it becomes a matter of trusting who's selling it, because there's no formal regulation of that. Does that answer your question?
Well, yes, you know, it's not a personal interest to me, but you see it on the news that parents say that the marijuana oils help their child who wasn't being helped before by conventional means.
Well, there are, the final comment about that is there are individuals who've responded amazingly well to CBD. It's not a miracle drug, I wish it was, but it's not as if everyone responds as amazingly well, but some people do. It's a matter of, it goes like any other medications, finding the right medication that works for that person. Question over here.
Yeah, I'm still not clear what the difference between a seizure and a convulsion is.
Thank you. So the question is, what is the difference between a seizure and a convulsion? And a convulsion is not really a medical term. We use it a lot in medicine, but it usually refers to a movement. And so in the United States, a convulsion usually indicates a stiffening of the body on both sides and then jerking after that. In Europe, sometimes a convulsion can just be part of the body. And so there's some disagreement about what is a convulsion. But regardless of that, it's really more a matter of the movement, the jerking and stiffening. But a person can have a seizure that doesn't have that jerking or stiffening. A seizure can be a staring off without anything more than maybe some fluttering of the eyes, or staring off blankly, or may have movements that are not convulsive in that they're stiffening and jerking, but maybe movements that are more padding or picking. And so,
But could you have a convulsion without having a seizure?
question is, can you have a convulsion without having a seizure? Yes.
The jerking, the extreme?
Yeah, so the convulsion is really the movement. So as a person can have a convulsion after certain head injury or medication reactions, and it wouldn't be related to a seizure at all. Convulsion refers to movements of some form. Question over here?
Yeah, can you speak a little to the phenomenon of temporal lobe epilepsy and creativity and also bipolar, effect on bipolar?
So questions about temporal lobe epilepsy and the relevance to creativity and bipolar.
Yeah.
And so I said earlier that seizures can start in one region of the brain, and it's like where that droplet lands, and it spreads out. And the temporal lobe, there are two temporal lobes here at the temples, is an area that is more likely than other areas to have seizures, but any area in this area of the brain can. And even within the temporal lobe, there's a certain area that is more vulnerable. It's more vulnerable to injury, it's more vulnerable to cause seizures, and that's temporal lobe epilepsy, or sometimes called mesial temporal lobe epilepsy, referring to one part of it. And this is a type of epilepsy that's been studied for a long time. There's an understanding going back decades about creativity in temporal lobe epilepsy, maybe artistic ability. Some of that has been second-guessed and wondered about how accurate the diagnoses were back then. I think, well, I'll throw out that the novelist Fyodor Dostoevsky very likely had temporal lobe epilepsy. Can't say for sure. He lived at a time before MRI and before EEG and before a lot was understood. But his descriptions of a seizure suggest possibly. And so people maybe have gathered on to some artists who've had it based on their descriptions. But it's hard to say whether it's really how it's connected to creativity, because obviously creativity exists in many different conditions. Temporal lobe epilepsy sometimes is associated with memory impairment. And that's an issue in particular because the temporal lobe is important for memory. It's going to be more steadfast. But you asked about bipolar, and I would turn that sometimes temporal lobe epilepsy is more likely associated with depression. Bipolar is a condition in which a person can have shifting mood from depression to elevated mood, sometimes called mania. What's more likely with temporal lobe epilepsy is more the low mood. And there's a greater likelihood for somebody with temporal lobe epilepsy to have depression. None of these things are, of course, universal. But it may be because that area of the brain is an area that is important for our experience of mood. And so it becomes part of understanding the overall condition for the epilepsy, is whether mood is another part of their condition that needs attention.
Thank you.
Question over here.
Yeah. Can the seizures, if they are shown with an MRI to have lesions in the brain and so forth, can that cause permanent, do the seizures cause the lesions, and then do seizures at some, I don't know, often or seldom or once in a while cause permanent damage to the ability of the brain?
So the question is whether seizures can cause injury to the brain, and whether you can see that injury on an MRI. And so this question of whether seizures cause brain injury has been investigated for over a century with great diligence. And it's not clear about an answer. There are situations where a person has a seizure that's prolonged, meaning lasting 30 minutes, an hour. It becomes a very life-threatening condition. And that situation may lead, because of the compromise to the heart and breathing, to a brain injury. But for a short seizure in a human, it's really hard to say whether that seizure has any consequence. The greater risk to the person is the circumstance in which the seizure occurs, in terms of accidents or injuries. The way I think about it is that we don't have definitive evidence that a single seizure in a human being causes that change. We can't say what happens over decades as well, but ultimately it comes down to preventing the seizures, and especially preventing the more serious seizures, because regardless of whether there's any small change or not, the reason for treatment is other than that. And we sometimes do see changes in MRI after many years of epilepsy, but we don't know if those are due to the seizures or not.
John, you said with brain lesions, is that something that can be created by a seizure or shrunken by a seizure, or do you find that they're just in the brain and they can affect things, or not affect things, or what's your experience as far as that?
So it was a follow-up question just now about the relationship between the lesions in the brain and the seizures. And to take it from a different perspective, when we see an abnormality in the brain in somebody who has epilepsy, it's not typically because of the seizures, it's the cause for the seizures. And so the abnormality in the brain could be an injury, it could be something that didn't form properly, it could be many different possible causes, but we think about whether that abnormality is the location of the electrical irritation. And so we don't think about that abnormality changing much because of seizures, although that's a research question. But we think about the relationship as being, that's the cause for the epilepsy. Not that the epilepsy caused that. Does that answer your question?
Yeah, I was thinking more in the context of seizures, but...
Yeah, so to clarify that we think about an abnormality and whether that abnormality causes the seizures, not whether the seizures cause the abnormality in most situations. Question?
If you're a witness to a seizure, what things should you be looking for?
The question is, what things should a witness for the seizure look for? Thank you for all these questions, but thank you for particularly for that question. The first thing I'm thinking about is first aid. So before thinking about documenting for the doctor later on, the most important thing is making sure the person having the seizure is safe. And so the reality is most seizures last between 1 and 3 minutes. It always seems like forever, because in a very stressful, difficult situation, 1 or 2 minutes seems like forever, and it will seem like 5 minutes. But we know from looking at large numbers of seizures that 5 minutes is a long seizure, even if it doesn't seem like that. So the first thing I think is important to do if you see a seizure is quickly look at the clock, look at the time. Because there's no way any of us can really estimate duration in a stressful situation. And allow the seizure to end, because there's not much you can do, there's not much anyone can do. There's not much that an ER doctor can do standing there that you can't do in that period of 2 minutes. What you can do is make sure the person's in a safe situation. And so if they've fallen, maybe move some space around them. If they have glasses and the glasses are getting punked into their head, take the glasses away, maybe loosen something around the neck. There's nothing you can really do to protect the mouth. And there's old wisdom about placing something in the mouth to protect the tongue. That doesn't help. It just means that something's in the mouth next to the tongue as the tongue gets injured. And so, the tongue may be injured, but there's not much you can do to prevent that at that moment. If the seizure lasts longer than 5 minutes, or if you don't know if this person has epilepsy, this might be the very first seizure that person ever had, there's a reason to call EMS, call for assistance, 911. But if this is somebody who's had seizures in the past, and this is their typical seizure, it'll last a couple minutes, it's not typically a reason to get paramedics. They're not going to do anything, because they're not going to be there until the seizure's over. When the seizure's over, it's important to let the person recover in a safe situation. If the seizure was a convulsion especially, and there's saliva around the mouth, maybe turn them on their side to let that drain out. Ask them if they're doing okay. Probably not get too close, because after a seizure sometimes people are confused. When they get confused, they might reach out, they might strike out to protect themselves, not knowing who you are, even if you're a family member. So it's a matter of safety and observation afterward. And if there's any injury, that's another reason to call for assistance. When thinking about what to observe, it's a question of whether the person had a warning, and if they did, what was it? You might have to remember the warning afterward, but to recognize what it was. And if they don't tell you the warning, but you can tell that they know it's going to start, that's still meaningful. That's something the doctor would want to know. Next is, how did it start? Did it start with a sudden stiffening? Did it start with staring off or movement of the hands? Did it progress from staring off to stiffening and a fall? It's really a matter of what the movements were, where was their attention, and how long did it last? And then, to repeat what I said before, whether they had a warning or some sense that it was beginning or not. Question?
Yes, this is a comment, not a question. We are so fortunate in not having a fellow. This is the lowest point in the hierarchy of medicine, and we are so lucky in having you rather than a fellow. Thank you.
Thank you. Please. Question.
Can you have a heart attack when you have a seizure? I heard it affects your heart or breathing.
So a large seizure, meaning a seizure that has the convulsion, the stiffening, will affect blood pressure, breathing, and the heart. And fortunately for most people, it's not a permanent injury of any sort. When a person has a large seizure, it's a stress on the heart. And somebody who has heart disease, that can be more of a stress and then can be accounted for, but that's something I unfortunately don't see very often.
Okay.
But it is possible that having seizures that are not controlled by medication over many, many years can change the heart in a way which can increase that likelihood of death, which is, I referred to you before about one of the consequences of uncontrolled seizures is it can be fatal. And one way is maybe through changes to the breathing and to the lungs, or respiratory drive, to use the technical term, not the lungs, but in the heart over time. Question back there?
Oh, well, never mind. I don't want to ask it. It's okay. Does cancer of the brain cause seizures, or?
So the question is whether cancer of the brain can cause seizures. And yes, a cancer on the brain, whether it starts in the brain or spreads to the brain, can cause seizures. And that is one thing that has to be looked into when a person first has a seizure, is whether there's a cause that needs attention besides a seizure, whether it is a cancer. The treatment is the same, though, in terms of preventing seizures. The treatment for the seizures is to decrease the risk of that electrical abnormality, whether it's starting from a cancer or from an injury.
Do football players get seizures, epileptic seizures? They have brain injury. They say that sports players, like football players, get brain injuries.
So the question is about sports players, football players having seizures, and there's a lot of attention to chronic traumatic encephalopathy, especially in football players. Seizures are not one of the major signs of that, for whatever reason. It's more of an Alzheimer's, or sometimes Parkinson's, but more Alzheimer's type of change. But I can't say it's not, things happen.
Yeah.
Other questions?
Another question here.
Do you have a worse chance if you have seizures that have been controlled to getting Alzheimer's? Does that have any effect on it?
So questions about whether seizures can lead to Alzheimer's disease, and the answer is no, that seizures are much too diverse, causes them, the epilepsies as well. And so it's really a separate condition. Sometimes memory becomes a problem with epilepsy, but it's memory for it's more the nuisance memory than the disabling memory. That's maybe understating it, but I mean, it's like, where did I put that down? People don't progress to the type of level of impairment that tragically can occur with Alzheimer's.